I appreciate your interest in my favorite topic, immune mechanisms in atherosclerosis and heart failure. My name is James Roberts. I'm board certified in internal medicine and cardiology, and I've been practicing invasive and now integrative cardiology in Northwest Ohio over the past 25 years. And over the past 5 years, my practice has been involved in researching new device, nutritional, and pharmacologic approaches to cardiovascular medicine. Now, immune dysregulation as a cause of cardiovascular disease was not something that I was taught when I trained in cardiology beginning 30 years ago. At that time, the focus of cardiology was on anatomy. There was a fixed blockage, a concretion, compromising the flow of oxygenated blood, rendering it insufficient to meet the demands of the exercising heart muscle. So my job was to do a coronary angiogram to determine the severity and extent of the narrowings, and then make a recommendation as how we could best resupply oxygenated blood with a percutaneous intervention. At that time, it was balloon angioplasty or a bypass surgery. If the pattern of blockages was such that we could not resupply you with oxygenated blood utilizing a revascularization procedure, we would use drugs to decrease heart rate, blood pressure, contractility of the heart, to decrease the heart's demand for oxygenated blood. It was all about supply, demand, and fixed blockages. And essentially, I was a doctor of blockages. I wouldn't see you until you had presented to the hospital with a complication of your atherosclerosis, unstable angina, heart failure, or an arrhythmia. My job was to stabilize you, typically in an intensive care unit setting with drugs and invasive monitoring, do a diagnostic study such as a coronary angiogram, and then refer you on for revascularization or a pacemaker or later on a defibrillator. And this was an enjoyable way of practicing medicine. It's quite stimulating treating people in the intensive care unit setting. The compensation was rather handsome, and it was gratifying because we would help you get better. But the problem was, as we were focusing only on the blockages themselves and the symptoms of the blockages, and not dealing with your risk factors, the abnormality in vascular biochemistry and cell biology that caused the blockage to develop in the first place, well, then you would be back with more problems. We would fix your right coronary artery. A few years later, you'd come back with a problem in your left coronary artery or in your carotid artery. And if we're focusing only on advanced lesions, we're not preventing the development of atherosclerosis in other individuals. So this became very frustrating. So about 15 years ago, I got interested in looking for and dealing with the abnormalities in biochemistry and cell biology that caused your heart disease to develop and which serve as driving forces for progression of your cardiovascular disease. And this is what I am known for. This is why you're seeing me. This is why you're looking at this DVD. 4 years ago, my colleague, Stephen Sinatra, and I wrote a book called Reverse Heart Disease Now, essentially a patient manual of integrative cardiology. And when we wrote this book, we did not appreciate the importance of immune dysregulation as a cause and driving force of atherosclerosis. But we understand now that inflammation and chronic infection underlies many of our standard risk factors and causes of cardiovascular disease. Now, in terms of full disclosure, I need to tell you that this talk is sponsored by my thymus gland, a wholly owned subsidiary of my entity. And it's important to be on good terms with your thymus gland, otherwise she could have a chilling effect on your heart. Now, I also need to apologize to all of you at my tardiness in producing this DVD presentation. We've been involved in immune mechanisms of atherosclerosis for 2.5 years. It's about time that I come out with the DVD presentation. Well, in my defense, I was ready last summer. I had all the literature in neat little piles on the basement floor. My wife became very irritated with me. She would put the laundry over the literature, and I would move the laundry and shuffle my papers. I was getting ready to put this together into a presentation, and then we had a rainstorm. And I came home, and there was this much water in the basement floor. All the papers were stuck together and soggy. The ink was running. Well, by then, the sun had come out, so we cleaned up the papers, put them out on the driveway, and the sun did indeed dry out these soggy articles. And then the wind picked up and blew all the literature across the neighborhood. So that really wasn't the right way to do it. What I should have done is gotten the ServPro people to clean up the basement, the guys like it never ever happened, but I didn't do that. Now, my daughter is a fourth-year medical student at the University of Cincinnati. That's where I trained. And in July, she'll begin her internal medicine residency in San Antonio. So we talk a lot about medicine. And because she's a medical student, a young healthcare professional, we talk pretty much in basic terms. So when we're talking about the disease that I'm dealing with, we know that it's associated with pronounced inflammation, a maladaptive inflammatory response, oxidative stress, influx and persistence of immune mediator cells, monocytes and T lymphocytes, high cytokine levels in the circulation within the lesions, and endothelial cell changes. And I ask her what this disease is, and she goes, gee, Dad, yeah, this is atherosclerosis. You're a cardiologist. Well, no, I'm not describing atherosclerosis. I'm describing another disease that she is seeing in her training, and that's tuberculosis. I just described tuberculosis, a chronic infectious disease. Now, tuberculosis and atherosclerosis are characterized by inflammation, activation of the immune system, oxidative stress, endothelial dysfunction, and tissue destruction, much of which is mediated by the immune system. The cause of tuberculosis is a specific bacterium, and tuberculosis. The cause of atherosclerosis is oxidized Ldl. We prevent TB and we treat TB by avoiding contact with the bacterium or by killing it with antibiotics. We're going to avoid atherosclerosis by preventing oxidation of LDL within the artery wall, and we will treat atherosclerosis by neutralizing oxidized LDL. Now, this is a difficult presentation for me to give. It'll be a difficult presentation for you to understand. We'll be speaking new lingo, cytokines, interleukins, T-cell subsets. Now, it's not important that you understand the details and all the biochemistry and the lingo, but I'd like you to sit back, open up your mind, and give me the privilege of trying to convince you that the cause and key driving force underlying atherosclerosis, that's arterial vascular disease, and heart failure is immune dysregulation, and that is my goal here. And I think that by the time we're done with this project, you'll have a pretty good idea of the lingo, and I hope to have convinced you to consider immune dysregulation as the key cause of cardiovascular disease. I'm going to ask you to change your supplements, change your medications, and probably pay for some treatments out of pocket, treatments that your insurance company will not be aware of for another 10 years. That is, if we have insurance in 10 years. Now, I'd like to present a case study to keep you interested and to show you the power of immune modulation in the treatment of patients with cardiovascular disease. This individual, 80-year-old female, came to see me in November of 2006. She was having dizzy spells. Her blood pressure was high, 180/80. We did a carotid ultrasound, just mild non-obstructive plaquing. Her EKG was non-revealing. Now, the dizziness turned out to be due to an inner ear problem, not a cardiac problem. And I offered to work with her on blood pressure reduction, risk factor reduction, and she wasn't really enthusiastic about it at the time. We did a cardiac echo, and it looked pretty good. There was maybe a little bit of hypokinesis, reduced systolic thickening over the back wall of the heart. The heart was somewhat hypertrophy, consistent with high blood pressure and age, but it was a pretty normal looking echo. And this is the apical four-chamber view, and this heart looks like dynamite here. Now, she came back a couple years later, not feeling too good. She was experiencing chest discomfort and shortness of breath. This has been going on for about a day and a half. Her blood pressure was lower, not because we had done something therapeutic, but because she was in the midst of a heart attack involving the front wall of the heart. Her EKG had changed, consistent with recent cardiac damage. Troponin is a protein that is made by the heart muscle, and it is released into the circulation only when the heart muscle is damaged. It's not supposed to be present in the circulation in a healthy heart. That will become important later. And her troponin level was elevated, consistent with ongoing cardiac damage. BNP, B-type natriuretic peptide, is a peptide released by the heart in response to stress or strain. It is a lab marker of heart failure. The upper limit of normal was 100. She was at 1,500. So she was in the midst of a significant heart attack, and she was in heart failure. And we repeated our cardiac echo, and the back wall now is not working well at all, and the front wall is not functioning. The front wall is enlarged and akinetic. This was a severe heart attack. Her ejection fraction is 30 to 35%, and there was thrombus, a clot within her heart. Now, she did not want to go to the hospital. She adamantly refused hospitalization. In any event, I would not do an acute cardiac catheterization on this heart because this heart was too far gone. All the damage that could be done had been done. So she wouldn't go to the hospital. So what we did, I treated her with all of the drugs that have been shown to be effective in the treatment of heart attack and all the nutritional supplements that have been shown in the cardiology literature to be helpful in the treatment of cardiovascular disease and acute myocardial infarction. Incidentally, we have a two-part DVD presentation on drug and non-drug approaches to heart failure and heart attack. And I put her on a blood thinner, Coumadin, and we had her use oxygen at home. I saw her every other day for 2 weeks, and she survived. And I was feeling pretty good about myself. This was pretty good work, keeping this woman with a recent heart attack and heart failure alive. And 2 months later, she was feeling better. Her chest discomfort, shortness of breath had improved but not resolved. I adjusted her medication slightly. Her EKG still showed evidence of a recent heart attack. Her BNP had fallen from 1,500 to 860. I repeated her echo, and there was really no change. She had had a large heart attack involving one or probably two walls of the heart. Well, at this point, we were just learning about immune modulation, and I thought, well, we ought to apply it to this patient because, why not? As well as the new homeopathic approach to cardiac stem cell stimulation, why not add this in? We have nothing to lose. And she did okay until 8 months out. She came in with palpitations. She was having an irregular heart rhythm. And I was surprised because, she had been doing well. Her chest discomfort, her shortness of breath had resolved. I'd kept her on all these pharmacologic and nutritional therapies. Her C-reactive protein was now normal, low levels of inflammation in the circulation. Her BNP is down to 212. It's almost back to normal. And funny thing, her EKG had changed. Her T waves had flipped. Now, if you come into the hospital with a closed artery and we open it up, your T waves will flip, and you might have an arrhythmia. We call these reperfusion phenomenon. Well, she wouldn't be reperfusing at 8 months. This didn't make any sense to me, so I repeated her echo, and it looked great. You can barely see any problem in the back wall of the heart, and in the apical four-chamber view, the heart looks essentially normal. This heart muscle that was not functioning due to a heart attack now basically had come back. This was the best clinical outcome I have ever achieved in my 25 years of practice in cardiology. And we were really excited about this. And the patient, the family were excited, the staff was excited. We needed a name for this therapy. I hemmed and hawed. I didn't really know what to call it. And then this is, again, the before, and this is after. You can see the dramatic improvement. So we decided to call this ServPro Infarct or ServPro Heart Attack Care like it never even happened. And this shows the power of immune modulation in the treatment of patients with advanced cardiovascular disease. Now, to give you an overview of the problem, relatively early in life, lipid particles will infiltrate the artery wall at areas of endothelial dysfunction and intimal thickening. They will be altered by inflammatory enzymes, causing them to clump together within the artery wall, where they are oxidized by free radicals generated by the cells of the artery wall. The oxidized LDL particle looks to the immune system like it's a microbe. This region will be infiltrated by immune cells, monocytes that become macrophages that engulf this oxidized LDL that looks like a microbe, causing a more intensive inflammatory response. Additional immune cells will be called into the artery wall. The endothelial cells will stop making nitric oxide. This allows smooth muscle cells to infiltrate into this region, thickening up the plaque, and the plaque will grow slowly. Ongoing oxidative stress and an immune response to additional oxidized lipids that enter the artery wall will accelerate the immune response. As the plaque expands, we see progressive deposition of lipids and macrophages and T lymphocytes. On the shoulder regions of the plaque, in areas where new oxidized LDL is being deposited, the inflammatory response may become intense. Interferon gamma and matrix metalloproteinases released by these activated immune cells will degrade the fibrous cap over the plaque. It will crack or rupture. The atherosclerotic gruel will flow into the flow area, causing a clot, causing the heart attack. At each step in the process, initiation, propagation of the plaque, plaque rupture producing a heart attack, immune dysregulation is involved. At each step of the process, if we can quiet the immune system, we can stabilize the disease or prevent it from even happening. The next section involves a discussion of lipid trapping. Now, we have ApoB100 protein containing lipid particles, that is LDL, lipoprotein A, and remnants. They will traverse the endothelium in high concentration if our lipid levels are high or if the lipid levels are small. We talk about small, dense LDL as being more of a problem than large LDL because it's easier for it to infiltrate the artery wall. Early in life, these particles will deposit preferentially in areas of endothelial dysfunction, intimal thickening. Laminar flow within our arteries tones up the artery wall and promotes arterial health. At regions beyond branch points, there will be an oscillatory or irregular shearing stress. This thickens the artery wall, causes endothelial dysfunction, so the lipids begin to deposit first beyond branches. This explains why atherosclerosis is irregular. High blood pressure and inflammatory metabolic factors will enhance this process, but the key driving force will be high levels of lipids. Now, LDL cholesterol, what is it? LDL has a spherical, kind of a flattened spherical configuration. It is a sac made of protein, which we call ApoB100, studded with phospholipids containing cholesterol and triglycerides. Now, we vilify LDL, we call it the bad cholesterol, but Mother Nature didn't give us LDL cholesterol to kill us. LDL cholesterol is food. Every cell in the body has an LDL receptor to bind and internalize LDL. We need LDL cholesterol to make cell membranes, bile acids, steroid hormones. A normal cell membrane contains some cholesterol and fatty materials such as phospholipids and unsaturated fatty acids. So we do need cholesterol, and there's a mechanism to bring LDL cholesterol into the cell. Now, so LDL cholesterol is not a problem except when the levels are elevated. What are the causes of abnormal or pathological hyperlipidemia? Well, in the United States, number 1 is bad diet. Number 2 is bad diet. Number 3 is bad diet. Number 4 may be low thyroid status. There are genetic factors. Lipoprotein A, which we'll talk about later, is under genetic control. Some people have LDL receptor impairments such that they cannot bring LDL into the cells of the liver appropriately, and they have a genetic hyperlipidemia. And actually, that's a gift from Mother Nature. You see, high levels of LDL will stimulate an immune response. So if on a genetic basis, a mother-to-be or the baby has a hyperlipidemia, their immune system will be activated. And this is important because the leading cause of death in the history of mankind is perinatal sepsis. Thus, a mutation to raise LDL was an adaptation to help us survive this period of our development. It's a problem today, but it's present. The gene is present in our population because it had value in the past. Hyperlipidemia leads to an inflammatory response. Heavy metals are a key problem underlying hyperlipidemia in our population, as is inflammation. Hyperlipidemia leads to inflammation. Inflammation leads to hyperlipidemia. Chronic infections such as gingivitis urinary tract infection, and in North America, where 2/3 of us are overweight, with high levels of inflammatory visceral fat, this is a key cause of inflammation. So many causes of inflammation can cause hyperlipidemia, so can heavy metals, so can hypothyroidism, and of course, poor dietary choice is the key here. Now, our body needs 800 milligrams of cholesterol. Cholesterol that we don't obtain from the diet, our liver will synthesize. Now, cholesterol itself is not soluble in blood, it's a waxy material, so the liver packages it up with proteins to form up blood-soluble lipoproteins. LDL's job is to ferry cholesterol from the liver to meet the needs of the cells of the body. We also have a mechanism mediated by the HDL particle to remove excessive or unwanted cholesterol from the cells of the body and from the cells of the artery wall. Now, the way HDL does this, there's an enzyme called LCAT, less of the cholesterol-transferase that's associated with the HDL. It will take a fatty acid from the second carbon position of phosphoryl choline, tack it onto cholesterol to make a cholesterol ester. It loads the cholesterol ester up into the HDL, takes it out of the body via the liver. Now, metals poison less than the cholesterol-transferase. Abnormal metals poison Mother Nature's system of reverse cholesterol transport. So if you're metal overloaded, you're going to have hyperlipidemia. Dr. Hal Huggins, who's the father of biological dentistry, demonstrated that mercury amalgam removal and detoxification nutritional intervention would lower your cholesterol. A paper that was published when I was in medical school showed that oral EDTA, a means of removing lead and cadmium from your body, will lower cholesterol. So metals raise lipids, metal detoxification will lower lipids. This is one of my own patients who we did a provocative challenge on, which we'll discuss later, showing a spill of multiple metals. Her LDL cholesterol was elevated between 180 and 190. We treated her with EDTA to remove lead and cadmium. Her LDL fell. We then treated her with DMPS to remove mercury. Her LDL fell further. Her problem was metal overload, poisoning the enzymes reverse cholesterol transport. We depoisoned her. Her cholesterol fell. That was a good thing. Inflammation will make your cholesterol rise. If we look at C-reactive protein is made in the liver in response to inflammatory cytokines such as interleukin 6. As the severity of periodontal disease rises, periodontal disease is most frequently encountered chronic infection, you can see the C-reactive protein rising. Inflammation of the gums becomes inflammation of the circulation, inflammation of the liver, C-reactive protein rises. Also, we will see as the severity of periodontal disease increases, so will your cholesterol. Inflammation from any source leads to hyperlipidemia. So we've got a problem in our society. We have hyperlipidemia due to poor diet, heavy metals, chronic infection, and inflammation. So these particles, LDL, lipoprotein and remnants are lipid particles that rise following a high carbohydrate diet, can enter the artery wall. Now, if they are going to be used as food, they will be taken up by the Ldl receptor. If no cell needs them, they can exit the vascular wall and return to the circulation, unless they become trapped. These lipid particles become trapped when they are altered by enzyme systems such as lipoprotein lipase and phospholipases that are upregulated in inflammatory conditions. Now, lipoprotein lipase breaks lipid particles down into small sizes. After we eat, the lipid in our bloodstream is called the chylomicron. It's a large globule that cannot enter the vascular wall. Lipoprotein lipase breaks it down into smaller particles. We talk about small LDL as being more of a problem because if it's small enough, it can enter the artery wall with less resistance. Lipoprotein lipase also tethers these lipid particles once they're in the artery wall to the proteoglycan ground substance. Lipoprotein lipase is manufactured by the cells of the artery wall, smooth muscle cells and resident immune cells. Basically, they want to keep their food source at hand. So lipoprotein lipase takes lipid into the artery wall. Now, the LDL particle, its outer protein shell is studded with phospholipids. And these phospholipids can be altered by these degradative enzymes. This is 1,2-dilinolenophosphatidyl or essential phospholipid. We'll talk about it later. It is a medicinal lipid particle, but phospholipids are 3 carbon fragments with 2 fatty acids and a phosphorylcholine molecule, and they make up much of the outer membrane of the LDL particle. Now, phospholipases that are induced by other inflammatory mediators or by heavy metals will break this bond here and release. It'll create a phospholipid with only 1 fatty acid, and this is called a lysophosphatidyl that is inflammatory. It stimulates the cells lining the artery to release inflammatory mediators, adhesion molecules to help pull in white cells to deal with this potential threat. It can also break off the fatty acid, and if the fatty acid is arachidonic acid that we get from meat and dairy in our relatively poor Western diet, we have a problem because arachidonic acid is converted into inflammatory prostaglandins and leukotrienes that mediate cardiovascular disease, weight gain, diabetes, pain, and fever. And we will have a subsequent section on fish oils. We want a lot of fish oils in our diet because they're non-inflammatory. Meat and dairy gives us arachidonic acid, aggravating inflammation in the artery wall. Now, these inflammatory phospholipase enzymes will alter the phospholipids. It will oxidize them, causing the LDL particles to clump together in a mass. And what you see here with a scanning electron micrograph of the inside of the artery wall, these are individual LDL particles stuck together. So they can't leave the artery wall. They will now be trapped within the artery wall. So we don't want to see this lipid trapping. So how are we going to prevent this? Well, first of all, have your levels of lipids, LDL, lipoprotein A remnants measured. And this is what we do. We follow our patients, we measure their lipids, and then we take steps to lower their lipid values, and then we repeat the measurements to make sure we're getting the job done right. We can also now look at lipid particle size because we want large lipids, not small lipids. We want to control the levels of the circulating lipids with proper diet, exercise, and weight loss, avoid and remove toxic metals, and deal with chronic inflammation. Deal with overweight, deal with chronic infection. And of course, we want to blunt the infiltration of these lipids into the artery wall by maintaining low blood pressure, taking steps to improve endothelial function. Because we don't want these lipids to get trapped in our artery wall because then they can become oxidized. So we can now move on to the next section on LDL oxidation. This section covers LDL oxidation. Now, LDL particles trapped in the artery wall will become oxidized if there's an imbalance between free radical oxidants and our antioxidant defense system. What are free radicals? A free radical, in a chemical sense, is an atom with 1 as opposed to 2 electrons in its outer shell. It is unstable and reactive. It will snatch an electron from an adjacent normal atom, quenching its thirst for electrons, creating a new free radical, which will in turn snatch an electron from the next atom. If an antioxidant, an electron donor, is not introduced, many atoms will be damaged, the molecule will be damaged, the organelle within the cell will be damaged, the cell will be damaged, it will become dysfunctional. If this is occurring in an LDL, it will become oxidized. Now, what are the sources of the free radicals? Well, many enzyme systems that govern our physiology generate free radicals as a byproduct. So there are normal sources of free radicals that are to be squelched by our antioxidant defense system. Immune cells that infiltrate the artery wall in response to oxidized, trapped LDL will generate free radicals, and heavy metals are a key problem with respect to oxidative stress in our society. Mother Nature didn't intend us to have any abnormal metals in our body. As a byproduct of using oxygen to generate energy, we generate superoxide and hydrogen peroxide. Mother Nature gave us enzyme systems that will quench these free radicals provided our diet has adequate minerals, which it tends not to. Now, superoxide or hydrogen peroxide, which are normally generated free radicals, in the presence of iron and copper at high levels, or especially any levels of toxic metals such as cadmium, lead, and mercury, are converted to hydroxyl. So we have a lot of free radical stress in our society because we are loaded with toxic metals and our diet is poor in antioxidant minerals. So we're all suffering free radical stress, therefore our LDL is likely to become oxidized. LDL cholesterol is not hurting us. Oxidized LDL cholesterol is killing us. Carotid intermediate thickness, which we'll discuss later, is a surrogate marker of atherosclerosis throughout the body. It measures your plaque-forming potential. Anything that increases your carotid IMT is very bad for you. Anything that lowers IMT is good for you. And if we're looking at predictors of high IMT, number 1 on the list is high blood pressure. Number 2 is hair mercury. Number 3 is whether you're taking lipid drugs. Number 4 is how much iron you're getting in your diet. Next is smoking pack years because that gives you cadmium. These are more important than advancing age. If we look at age-adjusted predictors of oxidized LDL, number 1 and 2 is mercury in the hair and urine. Then is nicotine exposure because that correlates with cadmium from smoking. Dietary copper, serum ferritin, which is a reflection of iron stores. The only nutritional factor that's protective is vitamin C, an antioxidant. Now, if we're looking at relative risk of a future coronary event compared to the lowest third, the lowest tercile, yes, being in the middle and upper terciles for cholesterol and LDL is a problem, but not nearly the problem as having a high oxidized LDL. This is our real problem. Again, LDL was given to us by Mother Nature as food. Oxidized LDL was something that is essentially man-made. It was not anticipated by Mother Nature. Now, this is carotid artery intermediate thickness. We do an ultrasound of the carotid artery. We're not looking directly for plaque, but what we do instead, we apply digital calipers to the artery wall and measure the thickness of the intima media. And that number, stratified for your age and gender, tells us a lot about your cardiovascular risk. Essentially, this tells us your propensity to generate plaque. The greater your IMT and the more rapidly that it increases in thickness, the greater is your risk for having cardiovascular disease. Conversely, factors that stabilize the IMT or regress the IMT are factors that will dramatically decrease your risk. And if we look at factors associated with rapid IMT progression, we will see a copper level above average, smoking above, being a smoker, having low selenium, or high cholesterol. And of course, there's a synergy here. The higher your cholesterol, the more cholesterol to be oxidized. The higher your oxidants, the lower your antioxidant minerals, the worse are your antioxidant defenses, the more likely will the LDL become oxidized, causing cardiovascular disease. If we look at people with a high LDL, this is a really problem if you're high in copper. But if you're low in copper, it's less of a problem. If you don't form free radicals, you're not going to oxidize your LDL. It won't be as toxic to your artery wall. If we look at individuals with high copper and high LDL, that's a big problem. But high copper, high LDL, and concomitant high selenium and antioxidant, the toxic effects of high copper, high LDL are mitigated. Individuals with high selenium have lower IMTs than individuals with low selenium. The only people that really get into trouble with high selenium are those with high copper, high LDL. It's a balance between pro-oxidants, antioxidants working on the LDL. So we want to prevent lipid trapping in the artery wall. We want to prevent oxidation of lipids in the artery wall. When the LDL particle becomes oxidized, this proceeds in 3 phases. First, the lag time with depletion of the endogenous antioxidants within the LDL. The LDL does contain many antioxidants, including vitamin E. They are used up. Then the phospholipids are oxidized. That causes the LDL to clump. And then the apolipoprotein B is oxidized as the final step. Now, when we oxidize these phospholipids, the phosphorylcholines studying the wall of the LDL or other lipid particles, we create reactive aldehydes. Malondialdehyde is a blood measurement of the severity of free radical stress. This creates abnormal biochemical reactions. Adducts with lysine and arginine within the apolipoprotein B are created. And this creates protein structures not normally seen in human beings. And this is oxidized LDL. Now, oxidized LDL was not present in the thymus during the development of your T cells. It is toxic to the endothelial cells, leading to endothelial dysfunction. These stress endothelial cells release chemotactic molecules that pull white cells in to defend against this infection with oxidized LDL, and adhesion molecules to help pull these immune systems into this focus of pseudo-infection. Now, the LDL, all of our cells, including the immune cells, the macrophages, have LDL receptors to internalize LDL and use it for food. But this oxidized LDL has been altered. It won't be recognized as food by the LDL receptor. Rather, it will be recognized by the scavenger and CD36 receptors of macrophages. Those are the receptors they use to recognize invaders like microbes. So to the cells of your immune system, oxidized LDL looks like a bacteria. So it will bind to and internalize the oxidized LDL and destroy it. Now, Mother Nature knew that this might happen because even primitive man was exposed to some degree of oxidative stress. So we have HDL, and its job is to prevent excessive accumulation of LDL within the artery wall and to block its oxidation. The higher your HDL, the lower will be your risk of atherosclerosis. Even individuals with the highest levels of LDL, if it is balanced by a high HDL, have a lower risk of cardiovascular disease. Conversely, at any level of LDL, as your HDL falls, your risk will be great. So we want to have a high HDL to promote reverse cholesterol transport and a lower LDL. How do we raise the HDL? Exercise, weight loss, fish oil, and niacin. Now, we can stimulate HDL activity with phosphatidylcholine. One phosphatidylcholine species in particular, 1,2-dilinyllenyl phosphatidylcholine, phosphatidylcholine with linoleic acid in its side chains, is particularly effective at stimulating reverse cholesterol transport. Less of the cholesterol acetyltransferase, the reverse cholesterol transport protein enzyme on HDL, will take linoleic acid from the second carbon position of essential phospholipid, tack it onto cholesterol to make a cholesterol ester, and that facilitates reverse cholesterol transport. Administering this material to animals and humans will prevent and reverse atherosclerosis. In an animal model, when you feed quail a high cholesterol, high oxidized cholesterol diet, they're going to fill up their aorta with plaque. But if you also feed them essential phospholipid, you will protect them. In humans, the administration of this material will reverse atherosclerosis. Under the trade name of lipostabile or N-essential, this material was utilized in Europe as a pharmaceutical agent. In fact, it is still a pharmaceutical agent, but it's off patent. Nobody's talking about it. When I studied the literature, I found 500 papers or abstracts documenting benefits of essential phospholipid in arterial disease, brain disease, and liver disease. And we use this material. I take this material orally and periodically IV. Now, this is an animal model discussing the use of essential phospholipid in a immune-mediated atherosclerotic model. This was done in cynomolgus monkeys, which are very similar to humans in their propensity to develop cardiovascular disease. Now, you gave some of the animals a standard diet. They had low cholesterol, a standard diet, and you immunized them against a cattle protein, bovine serum albumin, to cause abnormal inflammation. And that didn't affect the cholesterol. One group was put on a Western diet, their cholesterol rose. A group that received the Western diet and the inappropriate immune stimulation, there was a slight reduction in cholesterol. That was not significant. But the group that received the bad diet, the immune stimulation, and phosphatidylcholine, their cholesterol was lower. If you look at aortic esterase activity, which is an enzyme of reverse cholesterol transport, it was stimulated by the phosphatidylcholine. And if we look at the percentage of the aorta that was covered with plaque, there was no plaque with a normal diet. A bad diet or inappropriate immune activity alone, no problem. But if you stimulate the immune system and give them the bad hyperlipidemic diet, you get a lot of plaque. If you stimulate the immune system into an inflammatory mode, give them a hyperlipidemic diet, and give them essential phospholipid to promote reverse cholesterol transport, you have much less plaque. We're studying a new drug called dalcetrapib that blocks a protein, an enzyme called CETP that degrades HDL, and we're involved in a clinical trial of patients that have had a cardiac event. They're on lipid-lowering therapy. One group will receive placebo. One group will receive dalcetrapib. We know that dalcetrapib will double or triple your HDL. We're studying this to see will it have a beneficial effect in humans. So we have pharmacologic and nutritional strategies to raise HDL. We have essential phospholipid to promote HDL-mediated reverse cholesterol transport. HDL also has another enzyme called peroxidase that promotes reverse oxidation or reduction of oxidized LDL. And this enzyme is stimulated by bioflavonoids found in pomegranate juice. This study was done in Israel. They took individuals with symptomatic high-grade carotid narrowings, and they went out to the orchard and got some pomegranates, ground them up into a juice, and the patients drank this juice. Now, 3 of the patients did require carotid surgery, and they looked at the plaque. Those that had been consuming pomegranate juice had less cholesterol in their plaques, less evidence of lipid peroxidation, lower levels of malondialdehyde in their plaques. They had higher levels of glutathione, which is an antioxidant enzyme in their plaques, and less LDL oxidation. So the bioflavonoids in the pomegranate juice stimulated the antioxidant activity of HDL. How did the patients do? Well, they all got better. 3 required surgery because they had high-grade narrowings that were symptomatic. The rest improved. In the placebo group, carotid IMT progressed over time as we would expect. But in the pomegranate juice, the carotid IMT regressed dramatically from 1.5 to 1.0 millimeters. This is the best example of IMT regression that I have found in the literature. If you look at flow velocities in the carotid arteries, they regressed consistent with disease regression. Another study in the United States, they had individuals with coronary disease and abnormal stress thallium studies. They received pomegranate juice in a commercially available form called Palm Wonderful, and their nuclear stress scans improved. Now, we want to take in a lot of antioxidants. We want to take in vitamins and minerals to augment our antioxidant defenses. We want to free our body of toxic metals because if we're out of balance, our LDL is going to get oxidized, it's going to get gobbled up by these macrophages, and that will initiate the abnormal immune response that we call atherosclerosis. Now, the macrophages will gobble up the oxidized LDL, and the oxidized LDL is toxic to these cells. It'll kill them. So we have dead immune cells, essentially pus cells in the artery wall. We call this a fatty streak. But before these macrophages die, they send out additional distress signals. Chemotactic factors, the vascular wall elaborates adhesion molecules so other white cells floating around in the circulation can come in and serve as reinforcements. They will gobble up the oxidized LDL, snip it into little pieces, and present little snippets of oxidized LDL to T lymphocytes, and that actually is the trigger and driving force of the immune response. And we'll talk about that a little bit more in the next section. So how are we going to prevent oxidation of LDL that has been altered and trapped within the artery wall? Well, bolster your antioxidant defenses. Take antioxidant vitamins, antioxidant minerals, bioflavonoids, and ensure the adequacy of your program. We can do nutritional testing. The Spectre cell study, we look at your white cells, their growth rate in tissue culture with or without different nutrients. If the white cells divide slowly until we pour in B6, that means you're low in B6. So we can assess the adequacy of your nutritional program. We get this nice little graph comparing you to the rest of the population. We can do a 24-hour urine assessment for nutritional minerals. Most of you are low. Why? Because our diet isn't any good. The soil's been depleted of selenium and magnesium and zinc. And we take drugs that waste minerals, and toxic metals will displace nutritional minerals. So if you're low in a nutritional mineral, I need to supplement you. We can actually measure levels of oxidized LDL. That's the problem. Here are oxidized LDL levels in 27 of our patients and staff. Now, in green is low or normal oxidized LDL. There were only 4 people, and those were young, healthy staff members. Most of the patients were moderate or high. Of particular concern is individual 27 who had a moderate elevation in oxidized LDL, and we're concerned about patient 27 because patient 27 is me. Now, I run a marathon a year. I take all these vitamins, but I did have mercury fillings. I have lousy DNA, I know that, and I don't really practice all that I preach, so I've got kind of a high oxidized LDL. And so I saw that, and I have changed my ways, and I want to lower my oxidized LDL because I don't want to develop atherosclerosis. Now, it is important to follow a comprehensive antioxidant program. Mother Nature intended us to take in 96 different antioxidant substances every day. Certain antioxidants will quench certain free radicals, but not all of them. Vitamin E protects the cell membrane. Vitamin C works in the circulation. You can take all the vitamin C you want, but if you are low in the other antioxidants, that's kind of like having a football team with an all-star and other members of the team with broken legs. It's not going to work. Resist the temptation to take the new super antioxidant that you hear about in a mailer. It's fine to take that. It's wonderful. However, the basics must be fulfilled. In the United States, the medical community and the media is telling you that vitamins don't work. And that's based on some really stupid studies. They would take older patients with advanced cardiovascular disease, suffering intensive free radical stress, who are nutritionally deficient, and give them low doses of one antioxidant. And that's kind of like putting a flat tire on a car where the other three tires have been removed. Even if you gave high doses of vitamin C, it's putting a Michelin and 3 flats on the car. It's not going to work. Now, there have been studies showing that vitamin C and vitamin E improve outcome, and those are conveniently ignored by the cardiology community. But there have been studies where a cocktail of antioxidants were provided. The Indian experiment of infarct survival, a similar study done in Poland, showed that if you give a comprehensive program of antioxidants and minerals, you will improve cardiac outcome. And that's what we intend to do. So I'm going to coach your antioxidant defense team. We are going to ensure the adequacy of the program and then measure your free radical burden. Serum ferritin is a marker of abnormal iron absorption. This is a common genetic problem. If you have this, we have to give blood 3 times a year. We can do provocative challenges looking for heavy metals, which I'll talk about later. Remove from your environment sources of metals and free radical stress. Remove from your body all heavy metals. Give blood to lower your iron stores. Chelation therapy, a medical therapy to remove toxic metals from your body. Now, to understand what metals you have, I will do a provocative challenge. I will give you a cocktail of oral and intravenous chelators. Different chelators bind more or less avidly to different minerals, toxic minerals. So we will give you low to moderate doses of several different chelators to get kind of a snapshot estimate of your metal burden. Different people have different experiences in life. They have different metal burdens. So I want to treat you with a chelation program appropriate to the metals that you have. I don't need to treat you for metals that you don't have. Thus, we do a provocative challenge and then determine how best to treat you. EDTA is a hexadentate chelator. It looks kind of like a claw. We give it to you. In the pincers of the claw, it will bind a toxic metal and remove it from your body. It doesn't hang around in your body, it just removes metals. And it's specific for lead and cadmium. TACT is the trial to assess chelation therapy. This is an NIH-sponsored study. We're going to take 1,700 patients who have had a heart attack and who have recovered. We're going to give them standard post-heart attack medical therapy. They're going to receive 40 IV treatments over a year and a multivitamin. And the patients will be divided into 4 groups. A quarter of the patients will receive IV EDTA and a strong multivitamin, a 6-a-day multivitamin. That would be the standard of care in my practice. Another group will undergo metal detoxification and a week 1-a-day multivitamin. Half the patients will receive intravenous placebo. They will not undergo chelation. Half of them will get a strong multivitamin, half will get a weak multivitamin. So we can look at the benefits of a comprehensive vitamin and mineral program. Metal detoxification, we'll see if there's synergy between supplementing with good minerals and removing toxic minerals. Now, the study was set up to have 50 experienced chelating physicians, 50 previously non-chelating cardiologists, and they wound up with one invasive cardiologist who's been practicing chelation therapy for 15 years, and that's me. And we put 68 patients in the study, number 3 in the United States and number 1 amongst cardiologists. And we stopped randomizing patients 6 months ago. In about a year and a half, we will analyze the diet. We're going to be looking for heart attack, mortality, stroke. There'll be many other secondary endpoints, and the papers will come out in about 2 years. Another chelator, DMSA, is a relatively weak chelator of mercury and lead, but it can be administered orally. DMPS is our favorite chelator for mercury. It will remove lead. It doesn't remove cadmium. It can be administered intravenously or topically. And when the problem is primarily mercury, DMPS is my first choice. We can utilize magnetic field therapy to promote heavy metal oxidation. Mankind developed on the crust of the earth within a magnetic field. We are supposed to be walking around on the dirt barefoot or with leather sandals and receiving a negatively oriented magnetic field. If you sleep on a magnetic mattress pad that has a negatively oriented magnetic field, that mimics the force that Mother Earth gives us. And we will sleep in a cloud of augmented negative magnetic energy. And this magnetic field causes your electrons to spin, and then they're more likely to react with electrons from the next atom. Your whole biochemistry is increased. In a sense, we're going to transduce magnetic energy into biochemical energy. And we've demonstrated that static negative magnetic field therapy accelerates metal detoxification. If we look at how much mercury is in your urine overnight, at baseline there's low levels. If we put you on a sleep pad, you'll excrete more mercury on your own. If we use a sleep pad and a chelator, there's a synergy. So we will give you chelators and have you sleep on a sleep pad, and we get a more efficient detoxification. I'm using magnetic molecular energizer therapy. This is a 10,000-pound electromagnet that creates a magnetic field about 5,000 times more powerful than that coming out of the earth. And we utilize a formula in physics called the Larmor frequency formula. Basically, we can entrain unpaired valence electrons to revolve around the atom more rapidly. They will collide and interact with electrons from the next atom. We're basically accelerating your biochemistry. You can make more energy, you can use more energy, and this can be used to repair the cells, stimulate stem cells within the organ being treated, and it promotes metal detoxification. We're using this in our practice under the auspices of an institutional review board. It is quite helpful. This is a patient who I began working with about 6 years ago, and she had a breast cancer, and she was going to need chemotherapy, radiation, and surgery. But she had this advanced non-coronary dilated cardiomyopathy. All 4 chambers were enlarged, and she had mitral insufficiency. You know, this is pretty advanced heart disease. The chemotherapy that works in breast cancer is toxic to the heart. She can't receive that chemotherapy that she needs with a heart this bad. So we were kind of in a hurry to tune her up. So we treated her with metal detoxifiers to remove metals from her heart, because that plays a role in cardiomyopathy. We'll talk about that in DVD 2. And MME, and 2 months later, she went from this dilated cardiomyopathy with significant mitral regurgitation to a nearly normal heart with minimal mitral regurgitation. This is the power of synergy between magnetic fields and metal detoxification in cardiomyopathy. We did a pilot study of patients with atherosclerosis in my practice, 13 patients with known advanced coronary disease, most of them with prior bypass surgery, recurrent inoperable disease. We looked at symptoms, we did a stress echo, we did a carotid ultrasound, carotid impeded thickness, and we treated them for 6 months, and then we repeated the baseline assessment. Now, all the patients received a high-potency antioxidant mineral and fish oil. Some of the patients received a sleep pad. They all received phosphoryl choline. We used different chelation programs to see which would work best. And the point here was not to modulate the immune system. In fact, we did this study before I understood these immune mechanisms of atherosclerosis. The point of this study was to remove metals and supplement with minerals to block oxidation of LDL. If the fire is the immune response to oxidized LDL, the fuel for the fire is the oxidized LDL. So the point here was to block oxidation. And I'll give you a couple case studies, and these are all present on the heartfixer.com website. CJ was interested in an alternative to his 16th cent. He was 63 when I began to work with him in early 2007. His LDL was controlled on medical therapy at 83. He had an elevated lipoprotein A, elevated homocysteine, low free testosterone, prior mercury amalgam removal, but he had not undergone any metal detoxification. He had his first heart attack in 1996. This was followed by a total of 6 stents to the right coronary artery. Later on in 96, he had a stent to the circumflex. In 03, 3 more stents for restenosis. He had a heart cath in 2006. The right coronary artery had a high artery that was stented. The other arteries looked okay. I began working with him in early 2007. Well, he had a good LDL of 83 and HDL47 on medical therapy. He had an elevated lipoprotein A and a low free testosterone. This is a common theme. I typically see people who have inoperable recurrent cardiovascular disease. They're on statin drugs to lower their LDL, but for whatever reason, cardiologists in North America ignore lipoprotein A, homocysteine, and low testosterone. We will have a whole section on testosterone in the third DVD. Let's talk a little bit about lipoprotein A and testosterone with respect to their effects on immune dysregulation. Now, what is lipoprotein A? It's LDL with an apolipoprotein A particle attached to it, which is like Velcro. So lipoprotein A is a repair particle. It wants to repair the plaque. It wants to repair the artery after balloon angioplasty. If you have a high lipoprotein A and you undergo balloon angioplasty, you're going to restenose because your body wants to repair the particle. We don't talk about it in cardiology in the United States because while there are a number of drugs that lower LDL, there are no drugs that lower lipoprotein A, no money for research, no studies are published, so it's pretty much ignored, which is a big mistake. Now, because let's look at the interaction between lipoprotein A and the artery wall and immune dysregulation. 72 patients undergoing coronary atherectomy, so you're going to scoop out the plaque. You can look at it under the microscope. 26 of the patients had stable angina with a stable plaque with a fibrous cap. 18 had unstable angina. There was a rent in the fibrous cap due to immune activity. 28 had pain at rest. This plaque was red hot and active, and clots were forming on it, and lipids are being released into the lumen. So they have red hot angina. So you're going to evaluate these plaques for lipoprotein A, macrophage. Those are the white cells that are gobbling up the oxidized LDL, and smooth muscle cells. Smooth muscle cells enlarge the plaque, but they cause the plaque to become stable and resilient. If we go from stable angina in blue to unstable angina in red to rest angina, you can see that there's a greater deposition of lipoprotein A the more unstable or vulnerable is the plaque. You see fewer smooth muscle cells and more macrophages because the macrophages and the T cells are making interferon gamma that push the smooth muscle cells out of the plaque, rendering it less stable. Now here is the entire plaque area. Here we're going to stain smooth muscle. Here we're going to stain lipoprotein A and macrophages. You could see that where the lipoprotein and the macrophages hang out, there's no smooth muscle because the inflammatory mediators have moved the smooth muscle out, rendering the plaque less stable. If we look at lipoprotein A macrophage overlap, as the degree of inflammation rises, you see a greater overlap. The lipoprotein A enters the artery wall, it's sticky, it gets oxidized, it calls in the immune response that destabilizes the plaque. How are we going to neutralize lipoprotein A? Again, we have a 2-hour DVD on lipoprotein A that you can view. It's on the website. Now, lipoprotein A is primarily under genetic control. Levels will rise in association with hypothyroidism, statins, and trans fats. Yes, if you take a statin, your LPA level will rise. That doesn't mean you can't take a statin. It means your LPA level will rise, and we want to deal with it. Levels will fall a little with fish oil, niacin, estradiol in women, testosterone in men. But the key is to block the attachment of lipoprotein A. Lipoprotein A will bind to lysine and proline within the artery wall. If we supplement you with lysine and proline, the lysine and proline binding sites in the protein A will be occupied in the circulation with the lysine and proline we give you. It cannot attach to the artery wall. We also give you vitamin C to maintain the integrity of the vascular wall. So if you have high LPA, I'm going to give you vitamin C, 1,000 milligrams a day for every 10 points of LPA. Everybody gets 1,000 milligrams of lysine, 500 milligrams of proline twice a day. This is the protocol as recommended by Dr. Linus Pauling, who won the Nobel Prize twice. No one else has ever done that. I listen to guys like that. And this, I can't prove this with a paper, but in my 25 years experience in cardiology, this works. Testosterone we're going to talk about in detail later. Testosterone blocks translocation of nuclear factor kappa beta, which amplifies inflammatory signals into the nucleus, preventing it from transcribing inflammatory cytokines such as interleukin 6, interleukin 1 beta, C-reactive protein. It increases a regulatory cytokine, interleukin 10. It lowers elaboration of white cell adhesion molecules, vascular cell attraction molecule, and ICAM. Those are elaborated by the vascular wall to pull in the white cells. Those levels are decreased by testosterone, blunting immune cell infiltration of the artery wall. It lowers levels of matrix metalloproteinases. Those are degradative enzymes made from fatty acids that want to erode the plaque. So testosterone has a lot of immune benefits, and almost every man I see with cardiovascular disease is going to have a low or low normal testosterone level. Everyone I see with premature cardiovascular disease or family history cardiovascular disease typically has a high LPA. It's under genetic control. It's a key problem that we need to address. So in CJ, we dealt with lipoprotein A, and we treated him with testosterone. He had a high homocysteine. That means you don't have enough methylated B vitamins. We treated him at FEL. But he's still having chest pain at rest despite my best nutritional therapies. And I did a heart cath, and he had a lot of blockages, but they were beyond the reach of the balloon catheter, so he was not a candidate for further revascularization. We treated him with enhanced external counterpulsation to generate natural collaterals. He received 21 intravenous EDA treatments to remove lead and cadmium, 15 intravenous phosphatidylcholine treatments to promote reverse cholesterol transport. He developed a cardiac arrhythmia, atrial flutter, and I had to drop one of his angina meds and put him on a beta blocker. He had some kidney dysfunction because he was taking a lot of Celebrex for back pain, so his creatinine was elevated at 1.5, the upper limit normal was 1.3. So we put him into our magnetic sleep pad study. He received antioxidants, minerals, and fish oil, oral phosphatidylcholine. He slept on a 20 Gauss negative field only magnetic sleep pad, and as a chelator, he received EDTA mixed in with liposomes of phosphatidylcholine. This will ferry the EDTA into the circulation. And he got better. He got a lot better. His Seattle Angina Questionnaire, a rising value was good. His angina improved. His carotid artery intermediate thickness did not change much, but his carotid ultrasound did. I got a call from the vascular surgeon who was reading the scans in my patients. He goes, Jim, his right carotid artery got a little bit better, but the narrowing on the left, it's not there anymore. What did you do? So we melted away that plaque by removing, by lowering levels of oxidative stress, thus blunting LDL oxidation, thus blunting the immune response. Another patient, BG, a 63-year-old man with a high cholesterol, on treatment for diabetes, hypertension, his amalgams have been removed. In 2007, he had had a prior heart attack. His ejection fraction was 35 to 40%. That refers to how much blood the heart ejects with each beat. Normal is 50%. He didn't have heart failure, but frequent angina. He had a high LPA, low testosterone that we treated. We advanced the nutritional program. His angina improved, but it did not resolve. So we put him into our study, and he did improve significantly. His angina all but resolved. Beforehand, he could walk 5 minutes on the treadmill. He had angina at 3 minutes. 6 months later, he could walk for 9 minutes. Angina didn't occur at 4.5 minutes, which was quite fantastic. We were quite pleased with that. BF, 63-year-old hypertensive man with an untreatable lipid abnormality. His LDL cholesterols are sky high. Everybody had tried different drugs. He couldn't tolerate anything. He had a multivessel bypass in 85. In January of '01, he had a heart catheterization done. All 3 native vessels were closed. All of his vein grafts had closed. His left internal mammary to left anterior ascending artery was the only inflow route that was patent. And in '01, he had an abnormal stress test. I began working with him in '03. He was inoperable, so he was taking 3 nitros a day. Well, we found, yes, he had a high LPA. We began to treat that. He had a sky-high LDL of 267. We couldn't treat that. He couldn't tolerate any of the drugs. Elevated C-reactive protein, elevated homocysteine, which I addressed as best I could. He received external counterpulsation to generate natural bypasses from his well-perfused left anterior descending to the collateral-dependent right coronary in the circumflex, and that helped. Still had an abnormal stress echo. We gave him more ECP. As we'll discuss later, ECP not only does it attenuate your symptoms by improving collateral flow, it also has a direct immune modulation effect, a direct anti-atherosclerotic effect on the artery wall. And he got involved in our magnetic sleep pad study, and he did a lot better. His Seattle Angina Questionnaire improved. His carotid IMT did not really change, but there was some regression of his plaque. So his symptoms improved, and we had some modest plaque regression, which we thought was pretty good in a man with recurrent inoperable cardiovascular disease and untreatable hyperlipidemia. Again, it's not the high LDL, it's the oxidized LDL. If we get the metals out of the artery wall, less LDL oxidation, less immune activation, that's going to have a beneficial effect on symptoms and the course of your cardiovascular disease. So how are we going to prevent oxidation of LDL that's been altered and trapped within the artery wall? We're going to lower the LDL, and we're going to neutralize circulating lipoprotein A. The lower your LDL, the less that can enter the artery wall and get oxidized. We're going to lower blood pressure overall and lower your overall inflammatory burden to blunt LDL and LPA ingress and trapping. We're going to optimize your antioxidant defense systems, and we're going to remove free radical generating heavy metals. We're going to increase your HDL levels with diet, fish oil, and exercise. We're going to improve the functional activity of the HDL, pomegranate to increase the antioxidant function of HDL to reduce or to reverse the oxidation of the LDL, unsaturated phosphatidylcholine, essential phospholipid, to improve reverse cholesterol transport, because we wish to avoid LDL oxidation and immune system activation. Because if this occurs, atherosclerosis begins and progresses in a relentless fashion. So what I'd like to do next in the next section is introduce you to the fundamentals of the immune system. This section deals with the basics, the fundamentals of the immune system that we need to understand to better understand how our therapies work. Now, the cells of the immune system originate in the bone marrow. Lymphocytes can be T cells or B cells. The B cells leave the bone marrow and enter the peripheral lymphoid cells, the spleen, the lymph nodes, and there, under the direction of activated T cells, they will make antibodies. This is our circulatory or humoral antibody response to infection. That's not really important in atherosclerosis. We're not going to discuss it much. But the T cells, they leave the bone marrow and they enter the thymus, where they are educated. Now, within the thymus, they are exposed to major histocompatibility molecules. All the cells of our body have MHC molecules that express protein snippets of the proteins that are made within our cells to establish self-identity. And the cells of the immune system that gobble up proteins will chop them up into little pieces and express them on MHC2 molecules to show them to cells of the immune system. So when the T cells enter the thymus, they are selected to interact with MHC molecules. Otherwise, they would be worthless. But they can't react too tightly to the MHC molecules. Otherwise, they would cause autoimmunity. They would attack all of our cells. So T cells, developing T cells that bind too tightly to MHC molecules die in the thymus. This is an MHC molecule that sticks out of the cell membrane. In this cleft, it will present a peptide. This is a chain of amino acids, 8 to 20 amino acids large, that fits in this cleft. Whenever we make proteins in our cells, when they become old, they will become degraded. We will snip them up into little pieces. We will mount them on MHC1 molecules and express them on the cell membrane. This is an expression of self. My proteins are unique to me. So the protein snippets expressed on my cell membranes on MHC1 molecules are unique to me. My T cells understand that those are self, and they are taught to ignore these proteins as they're developing in the thymus. Now, if I receive a kidney transplant from anyone but an identical twin, the proteins expressed on the cells of that transplanted kidney on MHC molecules will not be mine. They will not be self, and my immune system will react against them. So the T cells are taught to ignore all the proteins that I make, or proteins that are not normally exposed to the circulation, and react violently to any other proteins. Now, the cells of our immune system will engulf and destroy invading microbes, chop them up into little pieces, and put little snippets on MHC2 molecules, so the T lymphocytes that are looking for work to do, they're looking for invaders, they're sampling these, and they know, aha, this is an invader. So our T cells are designed to be useful to recognize molecules presented to them on MHC1 and 2 molecules. So after these T cells are matured, they leave the thymus and enter the circulation and lodge in peripheral lymphoid tissue. These are our lymph nodes, our spleen, our liver, and there are lymph deposits in our GI tract, in our upper airway, our tonsils, and in our cardiovascular system. And they sit there until they find a protein that their receptor is specific for. They're going to be migrating in and out of all the lymph nodes of the body until they are activated. What will activate a T cell? We have 1 trillion different T cells with 1 trillion different T cell receptors that will respond to one shape and one shape alone. They don't do anything until they are activated by cells of the innate immune system. Now, within our tissues, we have dendritic cells. These are our first line defense against invaders. In the skin, we call them Langerhans cells. In the liver, they're called Kupffer cells. Monocytes that enter our tissues are called macrophages. These sentinel cells on their cell membranes have pattern receptors that will recognize the cell membrane of gram-positive and gram-negative bacteria, viral proteins, parasitic proteins, and they will stick to them and engulf them and destroy them. And at this point, they will hightail it to the nearest lymph node to sound an alarm that we're under attack. As these antigen capture cells migrate to the lymph node, they change from antigen capture cells to antigen presenting cells, and they arm themselves with co-stimulatory molecules to tell the T cells in the lymph node, we are under attack, get ready. Now, they will chop up these bacterial proteins, or if this is occurring in the artery, a snippet of oxidized Ldl, or if it's occurring in the heart, a snippet of myosin or troponin I, and they will present a small peptide fragment in an MHC2 molecule to all the T cells. And if that fragment matches the specific shape of the T cell receptor and co-stimulatory molecules on the antigen presenting cell interact with their receptors on the specific T cell, then an immune synapse is created and the T cell is activated. Now, if this protein material is presented to the T cell by antigen presenting cells that are not activated, without co-stimulatory signals, nothing happens. And anergy occurs, and the body will not mount an immune response. Conversely, if the antigen presenting cell presents non-inflammatory signals, then the T cells will recognize that protein as benign, and they will become regulatory cells, and then the body will be taught not to respond to that protein as a target. But in health, bacterial, viral, invader proteins will be brought to the lymph node by antigen-presenting cells that are armed. They're going to activate the T cell, and there's that 1 in a trillion T cells with the right receptor. It will elaborate interleukin-2, it will begin to divide, and all of a sudden we have a trillion of those T cells specific for that specific invader. That's how the immune response, it takes a few days for our immune response to respond to an infection. That's the time it takes for the T cells to proliferate, so there's enough of them to go to the site of the infection. There, they will assist other immune effector cells in dealing with the invasion. Th1 cells, their job is to assist macrophages killing intracellular bacteria, and pathologically, in the artery, they would be assisting macrophages in responding to oxidized LDL. Now, again, this is all shape specific. There's the MHC2 molecule on the antigen-presenting cell that presents a specific peptide fragment to the T cell receptor on the T cell. We have a trillion different T cells with a trillion different shape receptors. You've got to get the right peptide presented to the right T cell to initiate the immune response. And if you know what those antigenic determinants are, you can interact with the immune system, upregulate it, and conversely downregulate it. Now, the antigen-presenting cells, if they're armed and dangerous, if they express B7 that interacts with CD28 in the T cell, and they're making interleukin-12 that interacts with interleukin-12 receptor on the T helper cell, that will cause it to activate. And that T cell, if it's a Th1 helper cell, will enter the circulation, go to sites of infection, or pathologically, the heart or the artery wall, where it will interact with the macrophages. It will release interferon gamma that increases macrophage function to generate more free radicals. That's a problem if it's reacting to oxidized LDL, and it will express a CD40 ligand that interacts with a receptor on the macrophage to stimulate the immune system. Now, there are 4 different types of T cells, and what determines which way a T cell will differentiate is a complicated issue. The milieu in which this is occurring is important. Later on, we'll talk about how we can influence this milieu with vitamin D and fish oils. If the antigenic determinant is presented without inflammatory stimulatory signals or with anti-inflammatory signals, we'll get a T regulatory cell. T regulatory cells, their job is to tamp down the immune response. We want a lot of T regs if we have atherosclerosis or heart failure. Th2 cells assist B cells in making antibodies. As a general rule, they are protective against atherosclerosis. The antibodies they bind up the LDL and protect against atherosclerosis. Th1 cells and their first cousin, Th17 cells, they are our problem. Those are the T helper cells that drive forward atherosclerosis. They stimulate macrophages within the artery wall to produce more inflammatory mediators and advance the plaque and degrade the plaque. The major Th1 inflammatory mediators, otherwise known as cytokines, are interferon gamma, tumor necrosis factor, interleukin-6, interleukin-1 beta, and CD40 ligand. We don't want to see imbalance between Th1 and Th2, but because we're under oxidative stress, that tips the immune system towards a Th1 response, which is why atherosclerosis is so frequently encountered in our society. Now again, you're going to be Th1 or Th2. Part of it has to do with the milieu, which we'll talk about later. Part of it has to do with the characteristics of the invading microbe. Now, if the dendritic cells, the sentinel cells, the macrophages, if their pattern receptors recognize this microbe as, say, a bacteria that will be ingested and killed intracellularly by macrophages, as they're hightailing it to the nearest lymph node, they'll make interleukin-12. that will persuade the uncommitted T cell to become a Th1, and conversely, it dissuades them from becoming Th2. If, on the other hand, the invader looks like a parasite, parasites are too big to engulf, you want to kill them with antibodies, the antigen capture cell, the dendritic cell, the macrophage, will make interleukin 4 and express a receptor called jagged that interacts with a receptor on the uncommitted T cell called Notch, and that will convince the T cell to become a Th2. So Th1 versus Th2 is in part due to milieu and in part due to the perceived characteristics of the invader. Now, for our purposes, the pseudo-invader, that the oxidized LDL, which is mistaken for an infection of the artery wall, or snippets of myosin and troponin I that is mistaken for an invader in the situation of heart failure, those are recognized as intracellular microbes, and they stimulate a Th1 response. So if we have a Th1 response, these cells will release inflammatory mediators, including interferon gamma. Now, interferon gamma is a problem if you have cardiovascular disease, atherosclerosis, or heart failure. Now, if you're suffering from acute pneumococcal pneumonia, you want a Th1 and a Th17 response to make a lot of interferon gamma to kill the microbe. But if you have atherosclerosis, it's a problem. Interferon gamma is toxic to the endothelial cells that line the artery. So they will elaborate chemotactic factors and adhesion molecules to pull more white cells into this inappropriate site of immune system activation. Interferon gamma will, by lowering the amount of nitric oxide made by the endothelial cells, it allows smooth muscle cells to enter the artery, enlarging the plaque. Now, as inflammation becomes more intense and more inflammatory mediators are pulled in, interferon gamma will push the smooth muscle cells out of the plaque, rendering it less stable, and it will cause macrophages to release matrix metalloproteinases, which are degradative enzymes that eat away at the collagen, erode the fibrous plaque, causing the plaque to rupture, causing an acute cardiac event, such as unstable angina or heart attack. So this is a real problem. We'll talk about interferon gamma and the other mediators in later sections. Because we have a lot of interferon gamma, the plaque is going to progress and activate, the subject of our next section. This section talks about plaque progression and activation. Let's look at a study. We took 53 patients undergoing coronary atherectomy. So you're going to scoop out the plaque. You can look at it under the microscope. 28 of the patients had chronic stable angina, presumably stable plaques full of smooth muscle with a fibrous cap of collagen. 18 had unstable angina. There was some immune activation. There was a rent in the plaque. 12 had unstable angina with rest pain requiring intravenous heparin, a blood thinner, and intravenous nitroglycerin. Now, if we look at the plaque histology, its appearance under the microscope, all the patients have some fibrous tissue in the plaque. Atheroma is the gruel composed of oxidized lipids, foam cells, and immune cells. As the degree of inflammation increases, you can see that a greater percentage of the plaque is composed of this inflammatory gruel. You can also see that the inflamed plaques, the unstable plaques, have clots attached, because when the plaque fissures, platelets will stick to it and form clots. Sometimes the clots can break off, plugging up vessels downstream, causing a microinfarct. Sometimes they can enlarge and occlude the artery, causing a full thickness heart attack. So with increased inflammation, we see a greater frequency of clot and atherosclerotic gruel, immune activation within the artery wall. Now, if we look at percentage of the plaque area that is composed of smooth muscle, as the plaque becomes more inflamed and unstable, we see less smooth muscle. That makes sense. The plaque will now be more vulnerable. We see a greater frequency of macrophages, which are the cells that are releasing inflammatory mediators and chomping up and responding to the oxidized LDL, we see more antigen-presenting molecules, more MHC2 molecules. In response to interferon gamma, the endothelial cells will actually begin to act like antigen-presenting cells. They will engulf oxidized LDL and chew it up kind of like a macrophage and express it on MHC2 molecules, aggravating the immune response. We see a greater frequency of T cells the more unstable the plaque, because it's the immune activation that caused the plaque to become unstable. We see regions of plaque rich in smooth muscle are separated from those rich in macrophages. The immune active areas, they're pushing out the smooth muscles, they're degrading the collagen. This is the area of inflammation where the plaque will destabilize and rupture. Another study, we're going to look at plaque specimens from 54 atherectomy patients. One group had chronic stable angina, another unstable angina. A third group, the plaque had ruptured in a large clotted form causing a myocardial infarction or heart attack. We're going to look for macrophages, oxidized LDL, the membrane attack complex of complement, and C-reactive protein within the artery wall. Now, the relative frequency or density within the plaque area of macrophages will rise with increasing degrees of plaque instability, and that makes sense. The T cells and the macrophages are working together to make inflammatory mediators to enlarge and activate the plaque. C-reactive protein is a marker of inflammation. It's made in the liver in response to circulatory inflammatory mediators such as interleukin 6. So C-reactive protein in the circulation typically reflects inflammation in the body. In America, it's overweight or chronic infection. But we also make C-reactive protein within the plaque in response to inflammation. Intraplaque C-reactive protein is toxic. It kills the endothelial cells. So with a more unstable plaque, we see more intraplaque C-reactive protein. If you look for the simultaneous presence of macrophages, C-reactive protein, oxidized LDL, and activated complement, as you go from stable angina to unstable angina to heart attack, you see greater evidence of immune inflammation. Again, immune inflammation and immune frenzy drives the plaque to enlarge, and it's the cause of plaque destabilization. A vulnerable plaque is a plaque associated with intense Th1 and Th2 mediated inflammation. Now, these T cells that are present in plaque are responding to specific antigenic determinants. Antigen-presenting cells have gobbled up proteins, snipped up in little pieces, and presented them on their MHC2 molecules to the T cells. If we look at an unstable plaque, we will find 20 to 40 clones of specific T cells in large numbers. This is called oligoclonal proliferation. Now remember, you have 1 trillion different types of T cells, but there are 20 to 40 antigenic determinants within the artery wall that are the targets of 20 to 40 different types of T cells with specific T cell receptors. You can determine what the antigenic determinants are by taking T cells from plaque or from blood, putting them in a test tube situation, exposing them to different proteins or antigenic determinants, snippets of different proteins, along with an artificial antigen-presenting surface, or you could put in antigen-presenting cells to mimic what's going on in the artery wall, and you can look at the rate of proliferation of the T cells and determine what are the specific antigenic determinants that are driving forward this abnormal immune response in the arteries, in the heart, or any other organ subject to immune attack. Now, what are these antigenic determinants? Now, of interest, if you look at the antigenic determinants in an unstable plaque and in a stable plaque in the same individual, they're very different. If you look at the T cells in the blood of an individual, different families, you get these bell-shaped curves because all trillion T cells are sort of floating around. But if you look at the artery of a patient with unstable angina, you will see that 20 to 40 clones of T cells have proliferated. And the T cells in one artery are not identical to the T cells in another artery. They're reacting to specific antigenic determinants. And the T cells that we see in an unstable plaque are Th1. You see a lot of MHC2 molecules, and these T cells are making Th1 cytokines such as interferon gamma, interleukin 6, interleukin 1 beta, tumor necrosis factor. What you don't see are T regulatory cells. You also see Th1 cells that have gone autonomous, and these are Th17 cells and a class of Th1 cell that I'll talk about in a moment called CD4 plus CD28 null cells. So you'll see a specific number of different T cells that have proliferated wildly, and their characteristics have changed, rendering them autonomous. So unstable angina, in a sense, is a lymphoma of the artery wall. T cells out of control. Now, what are the antigenic determinants that bring in these T cells that proliferate and go out of control? Well, 10% of the T cells in an unstable plaque will recognize protein snippets from oxidized LDL. That is the initial culprit. Beta-2 glycoprotein is found in the artery wall. It becomes antigenic when it's oxidized, as does heat shock protein, which I'll talk about. And 50 different microbes have been found in the artery wall. 50 different bugs are present in the artery wall. How did they get there? What is their significance? Now, 12 years ago, two Finnish researchers, Kiander and Shefsholu, isolated Nanobacterium sanguineum. This is a tiny calcium-forming bacterium that they grew live out of kidney stones and calcified plaque. You can find these critters wherever you find abnormal calcification in the human body. Kidney stones, dental pulp stones. A therapy was created to treat atherosclerosis by treating Nanobacterium sanguineum. And it contained antioxidants and minerals and fish oils and vitamin D and vitamin K2. And it contained EDTA, which binds calcium to poke a hole in the shell, and tetracycline to kill the microbe. And I applied this therapy to my patients, and we observed in some patients profound reversal of coronary calcification. The coronary calcium score typically progresses by 40%. No one has ever shown that you can stabilize it or reverse it with a drug. However, in this patient, the coronary calcium score fell by 2,000 points with anti-nanobacterial therapy. A colleague published a series of 77 patients that he treated with what was called COMET therapy, EDTA, and tetracycline, and 57% responded with a decrease in the coronary calcium score. The mean reduction was 14%. Now, the natural history is to progress by 44%. Angina resolved or significantly decreased in 84%. This was published not in a cardiology journal because nobody wanted to hear about it, but in a journal called Pathophysiology. And our experience was that it was effective as well. So we were really excited. We had found the H. pylori of atherosclerosis. Now, as you're aware, peptic ulcer disease is due to infection with H. pylori. And when Dr. Marshall of Australia first proposed that peptic ulcer disease was due to infection, we all laughed at him because we knew that peptic ulcer disease was due to hyperacidity. When I was training in internal medicine, if you had peptic ulcer disease, we would put a nasogastric tube down you and drip in cream because the cream was supposed to neutralize the acid. That didn't work too well because it's really due to infection. So now we treat peptic ulcer disease with antibiotics. So we thought, yes, we found the H. pylori of atherosclerosis until other groups came out showing that you can find H. pylori in atherosclerosis. Indeed, many bugs can be found in the artery wall, typically dead. It turns out that the greater the number of bugs that you have high titer IgG antibodies to, representing past or current infection, the more aggressive and extensive is your cardiovascular disease. Endothelial function, the ability of the artery wall to make nitric oxide and dilate, deteriorates the greater the number of infections that you bear. If we look at outcome following balloon angioplasty, restenosis, heart attack, or death, the greater your infectious burden, the worse you do. If we just look at 3-year mortality in patients with cardiovascular disease, the more bugs you've been exposed to, the worse you do. So infectious burden plays a role in the natural history of cardiovascular disease. Well, why? How do these bugs get into the artery wall? How does infection aggravate atherosclerosis? Well, the bugs, in theory, can invade the artery wall along the endothelial surface, or there's a blood supply to the outer reaches of the artery called the adventitia. So there could be infection of the artery with bugs that get into the circulation. But the greatest issue is monocyte hitchhiking. Now remember, an inflamed plaque is releasing chemotactic molecules and adhesion molecules, so any monocyte floating around in the circulation, if it comes across that plaque, it will be pulled in. So let's say you got gum disease, or you got H. pylori, or you got a urinary tract infection, or a skin condition. White cells will enter those regions, gobble up the bacteria present, begin to kill them, they'll enter the circulation to go to a lymph node. If in that process they're floating around in your coronary arteries, they come across an unstable plaque, they're going to get pulled in to help out fighting this battle, this pseudo battle against oxidized LDL, where they will die, leaving their protein snippets of microbes obtained elsewhere in the body into the artery wall. So those protein snippets will be presented to T cells. So we will see T cells in the artery wall of a patient with plaque specific for microbes that were picked up elsewhere in the body. So these bugs aren't really invading the artery wall. Their carcasses are being brought in, but their carcasses aggravate the immune response. In a moment, we'll talk about toll-like receptor upregulation, but I'd like to talk about heat shock protein molecular mimicry. Now, heat shock proteins are defensive proteins. When a cell is being attacked, if it's under stress, it will elaborate heat shock proteins to stabilize the skeleton of the cell. These heat shock proteins work really well. So the amino acid sequence of human heat shock protein is 98% identical to that of microbes like E. coli and H. pylori and C. pneumoniae. Now, if we are invaded with a bacteria, we will mount an immune response against the bacteria. The cell will be stressed. To preserve itself, it will elaborate these heat shock proteins on its cell membrane. We will then mount an immune response against these heat shock proteins as an abnormal invader, and we'll kill the microbe. So we've got an immune response against microbial heat shock proteins. Now, they're not going to bother our own endothelial cells because they're healthy. They will not be elaborating heat shock proteins. But if you're a smoker, or you're full of heavy metals, or you don't take care of yourself, the endothelial cells that line your arteries are going to be stressed. They will elaborate human heat shock proteins that really look to the immune system pretty much the same as microbial heat shock proteins. So our immune response against various and sundry microbes will cross-react with heat shock proteins expressed by stressed human cells. Now, during the winter months, we have more upper respiratory infections, but healthy people don't have more heart attacks. Smokers, who always are elaborating heat shock proteins on their endothelial surface, they have an increased frequency of heart attack in the winter because when they have an infection, they mount an immune response against bacterial heat shock protein. It reacts against their own heat shock protein. Thus, they have an increased risk of unstable antigen heart attack. So the more bugs you got floating around, the greater will be your immune response against heat shock protein, the greater is your chance of an autoreactive immune response. Now, heat shock protein is a normal constituent of all the cells of the vascular wall, the endothelial cells, the smooth muscle cells, the macrophages. But in a damaged artery, and by definition, plaque is damaged, the cells are going to make a lot more heat shock protein. So if we go from transition zone to fatty streak to full-fledged plaque, we'll see greater heat shock protein, and the immune cells will react against heat shock protein just as they do to oxidized LDL and oxidized beta-glycoprotein. Now, we have these receptors on our macrophages, on our dendritic cells, on our sentinel cells that will recognize gram-positive bacteria, gram-negative bacteria, etc. We also have toll-like receptors. They don't recognize microbes, but they transduce threat signals. When the toll-like receptor of a macrophage is activated, it upregulates, gets pissed off, it gets activated to go out and kill some microbes. Bacterial cell wall polysaccharide, saturated fats, tumor necrosis factor alpha, cellular debris are all threats. They stimulate the toll-like receptor and they upregulate the immune response. So the more infections you have, the more your toll-like receptors are activated, the more angry are your macrophages, the more likely they are to oxidize LDL and destabilize the plaque. Now, these toll-like receptors, they're really complicated, and I've studied them to a great degree, and they're very important mediators in cardiovascular disease. But I figure, if the toll-like receptor is important, well, the toll receptors must be even more important. Now, the group I'm working with is based in the Orient. So every quarter I spend 2 weeks in the Orient studying from these guys, and I'm learning a great deal. But when I'm back here in the States, I'm communicating with them, and it's kind of difficult because when I want to work, they want to sleep. So we're really communicating over the internet a lot, and there's a little bit of a language barrier. So I was emailing them, I want information on toll receptors. So they send me back something that didn't really make any sense. It wasn't very satisfying to me. And I kept pushing and pushing, and they said, well, okay, they're going to have their chief professor show me exactly what is a toll receptor. So I got this in the email, a toll receptor in China. Now, other links, genetics, endotoxin load, allergy, and visceral fat will all upregulate our immune response, increasing our likelihood of Th1, Th17, upregulated immunity. We can look at the interaction between genomic upregulations. We all differ genetically, and in this study they looked at upregulation for interleukin 6. If you're really good at making interleukin 6, you're really good at killing bacteria, and you're going to have fewer significant infections as you grow up. But you're also going to have more cardiovascular disease because while we want a good immune attack to kill real bugs, the chronic immune upregulation characteristic of atherosclerosis is killing us. So the more genomic upregulations you have for interleukin 6, or you could do this for tumor necrosis factor alpha or for toll-like receptors, the greater will be your carotid intermediate thickness. Endotoxin load. All of us have bacteria in our blood all the time. Bugs are leaving our gums, our GI tract, our bladder. Those of us with chronic infections have greater levels of endotoxin in our circulation. The greater the endotoxin reflecting infectious burden, the more will our toll-like receptors be upregulated, the more our immune system will have a hair trigger to cause atherosclerosis and heart failure. Allergy is associated with immune upregulation, and we'll discuss this in a later section, but individuals with allergy, even allergic rhinitis, are at greater risk for subsequent cardiovascular disease. The link between obesity and cardiovascular disease is that visceral fat is loaded with activated immune cells releasing Th1 cytokines. So overweight is a key driving force behind atherosclerosis. We'll talk about that a little bit in the next DVD. Now, this is all about immune system balance. We want a balance between Th1 and Th2. Yeah, if I'm septic from a microbe, I want a vigorous Th1 and Th17 response. Go kill them. But then a few days later, after the microbes have been killed, I want T regulatory cells to rise to tamp down the immune response. It's all about balance. If you have an acute coronary event, by definition, you've been out of balance for a long time. And on the day of the event, your immune system is totally off balance. Too much Th1, too much Th17, no Treg activity. So this is a problem of immune system imbalance. Now, I want to talk about a specific subset of T cells. CD4 plus CD28 null T cells. We're going to look at 120 consecutive patients with unstable angina. Now, group 1, this is their very first cardiac event. Otherwise, they have been healthy. Group 2 had a prior cardiac event within the preceding 2 years. This is their second event. Group 3 had a prior, the index, and a subsequent event, at least 3 events. And group 4 were people with chronic stable angina. They'd never had an event. And you're going to look at the frequency of CD4 plus CD28 null T cells. Now, normally, for a naive or resting T cell to be activated, it is presented with its specific antigenic determinant by an antigen-presenting cell armed with a co-stimulatory molecule, B7, that interacts with CD28. Without that interaction, the T cell will not activate and proliferate. CD4 plus CD28 null cells have lost CD28. What happens as a result of chronic recurrent inflammation with the same antigenic determinant, or in normal physiology, the same microbe, these T cells change, giving themselves a hair trigger. They don't need co-stimulation. And that would be a good idea if you're repetitively being exposed to the same microbe. You don't want your immune system to take a couple of days to ramp up. You want it to go after the bugs immediately. So in response to chronic stimulation with the same antigenic determinants within the artery wall, will our T cells change where they lose CD28 and go autonomous? Now, the normal Th1 helper cell with CD4 plus and CD28, it is a Th1 helper cell. It doesn't kill cells, but when they lose CD28, that T cell also becomes a killer cell. And if it interacts with CRP, it'll kill the endothelial cells. A normal Th1 cell will make interferon gamma and interleukin 12 only in response to its specific antigenic determinant. Well, the 28 null cells, they'll make interferon gamma and IL-12 all on their own. The Th1 helper cells activate monocytes and macrophages locally. They have to be right next to them. But the CD28 null cells actually break into the circulation, releasing interferon gamma, activating all the monocells in the circulation. It's sort of metastatic inflammation. The normal T helper cells cause local inflammation within the plaque. When they lose 28, they will cause systemic inflammation. The normal Th1 cells respond only to its antigen. These other cells, they've basically gone malignant. They can live for a long time, entering the circulation, activating the immune system elsewhere. We see these 28 null cells, these autonomous cells, at high frequency with acute coronary syndromes, high frequency and unstable or vulnerable plaques. They activate monocytes and promote infiltration in the enema, and they're the link between cardiac events and vascular events elsewhere. For example, if you have a 70% narrowing in your carotid artery just sitting there not causing any trouble, it is more likely to activate within 6 months of a heart attack than before, because the CD28 null cells released from the unstable plaque activate all the monocytes in the circulation, and it can seed the carotid plaque, causing it to activate. So inflammation begins local and it becomes systemic when the T cells proliferate and they go out of control. So we don't want to see the 28 null cells. Anything that will lower the frequency of the null cells would be beneficial in a patient with cardiovascular disease. And what you see, individuals where this is their first event, 2.3% of their T cells have lost CD28. Those with one prior event, it's 5%. Those with prior and future events, people who are on their way for open heart surgery or death, it's 9.5%. Because the reason they're having recurrent disease is because their immune system is pathologically activated. The T cells have gone autonomous. Now, if we look at the relationship between the number of prior events and the percentage of your T cells that have lost CD28, one prior event, it's 2.5%, 2 to 3 prior events, it's 8%, 4 to 5 prior events, it's 14%. The more active, the more autonomous your immune system, the more trouble you are going to have. If we look at a relationship between C-reactive protein and the percentage of the T cells that lost 28, there's a linear relationship because C-reactive protein in the plaque and in the circulation is a reflection of immune activation. Survival is poor in individuals with high frequencies of CD28 null cells. Now, in this study, some of the patients were given a statin, some did not receive a statin. Now, this was not a randomized double-blind statin study. Some of the doctors put their patients on statins, some didn't. And you'll see that those who took a statin had a lower frequency of CD28 null cells than individuals who did not take statins. And if you look at 2-year event rate, those individuals that did not have high levels of CD28 null cells, event rate was the same whether you took a statin or not. Those with intermediate levels of CD28 null cells, statin therapy provided no protection. Actually, their event rate was 30%. Those not on statins, it was 25%. Statins didn't help. But if you look at people with really high levels of CD28 null cells with out of control immune activation, the group that received a statin did a lot better. Their event rate was 33% versus 64% without statin. And we're going to talk about statins in atherosclerosis and heart failure a little bit later, but statins are immune modulators. They were marketed to lower cholesterol, but we use them as immune modulators. They downregulate Th1 and Th17. So the more active your immune system, the more inflamed you are, the greater will be your relative benefit of a statin. If you're young and healthy, you have a high cholesterol, statin's not going to do much for you. But if you've had 2 open heart surgeries and your immune system's out of control, statins are like chemotherapy for this out of control immune response within your artery wall. Now, interferon gamma is the major Th1 cytokine. Let's study that a little bit more. Interferon gamma is released by activated CD4 plus CD28 null T cells. It binds receptors on non-activated circulating monocytes, so it's activating all the immune cells in the circulation. It causes a molecule called STAT1, signal transducer and activator transcription, to leave the cytoplasm, go into the nucleus, and initiate the transcription of a bunch of inflammatory genes, including CD64 and IP10, which we don't need to remember other than for the purposes of this study. If you see STAT1 in the nucleus or transcription of these 2 proteins in peripheral monocytes, that reflects recent activation with interferon gamma. We can't measure interferon gamma, we can measure the result. So we're going to evaluate monocytes obtained from individuals, 36 with unstable angina, 33 without unstable angina, and 20 healthy age-matched controls, and look for fingerprint of interferon gamma. And what you find, CD64 expression representing activation of the circulation with interferon gamma. You don't see any more with stable angina than with controls because the immune response has not gone systemic. But in those with unstable angina, the CD28 null cells and the Th17 cells, which we'll talk about a little bit later, they've released interferon gamma into the circulation. You'll see more CD64 expression. If you take these monocytes and you put them in a test tube and you pour in interferon gamma, the healthy monocytes obtained from healthy people will respond appropriately, as you would expect if they're exposed to interferon gamma released in response to pneumococcal pneumonia. But the cells obtained from individuals with stable angina make a little bit more. Those from individuals with unstable angina, they make more at rest, and in response to exogenous interferon gamma, they make more. They have been primed. So when you have this unstable cardiac event, your whole immune system goes on this hair trigger. This is why you're more likely to activate plaques elsewhere in your body. It's all about immune system balance, and if we're in imbalance, we have coronary disease and congestive heart failure. As part of therapy, we want to put you in balance. We'll talk about changing the milieu by blunting oxidative stress, vitamin D and fish oil, to increase Treg activity. We're going to talk about pharmacologic and nutritional approaches to downregulate Th1 and Th17. Let's talk about the balance between Treg and Th17. Th17 are Th1-like cells that are also somewhat autonomous. They're kind of like the CD28 null cells. 85 adults undergoing heart catheterization. 26 with a heart attack, acute infarction, 17 unstable angina, 22 stable angina, their plaques are stable, 20 individuals with non-coronary chest pain. We're going to look at the T cell characteristics. Are they Treg? Are they Th17? We'll look at cytokine levels. Transforming growth factor beta, interleukin 10, are Treg cytokines that quiet down the immune response. Th1 cells make interleukin 6, tumor necrosis factor alpha. Th17 cells make interleukin 17, interleukin 23. Now, first of all, we're going to look at the frequency of Treg cells that quiet down the immune response. 5% of the T cells in individuals with normal coronary arteries are Treg. Stable angina, unstable angina, heart attack, you see less. The immune system of the individual with advanced atherosclerosis, in general, there's fewer Treg cells in the circulation. Conversely, as sort of a mirror image, you see a greater frequency of the go out and get them and attack Th17 cells. If we look at cytokines in the circulation, transforming growth factor beta, interleukin 10, they're good guys from our point of view. They're elaborated by Treg cells. As you go from non-coronary chest pain to stable angina, unstable angina, heart attack, you see less of these Treg cytokines. You see more interleukin 6 and CRP, which is Th1. You see more interleukin 17, more interleukin 23, which is Th17. These people are way out of balance. Treg to T17 balance versus oxidative stress. Now, we talked about oxidation causing LDL oxidation to initiate the immune response. We're also learning that oxidative stress in general, anywhere in your body, will unbalance the immune response, increasing the likelihood of abnormal immune activity in the arteries, in the heart, and elsewhere in your body, will lower the amounts of Treg cells throughout the body. 133 adults undergoing a heart catheterization, 30 with a heart attack, 32 with unstable angina, 31 with stable angina, 20 with non-coronary chest pain. We'll look at T cell characteristics, we'll evaluate cytokine levels, then we're going to incubate the T cells obtained from these people with exogenous oxidized LDL and see how the oxidized LDL affects them. Now, first of all, as we go from normal coronary arteries to heart attack, we see fewer Treg cells, more Th17 cells. FOXP3 is a transcription factor for Treg. The orphan receptor for retinoic acid is a transcription factor for T17. You see the same basic pattern. Now, cytokine levels, you see less regulatory IL-10, more inflammatory IL-17. In individuals with non-coronary chest discomfort and stable angina, you see fairly low levels of oxidized LDL. You see higher levels with unstable angina and heart attack because that oxidation is inflaming the plaque. Now, what you do, you're then going to take T cells from these people and expose them to exogenous Treg cells. And what you'll see, the Treg cells will decrease the rate of lymphocyte proliferation by 82% in individuals without heart disease. But if you have heart disease, particularly if you have unstable inflamed heart disease, the Tregs are less effective. That's because your immune cells are oxidized and upregulated. They're more likely to escape suppression by T regulatory cells. This is due to oxidative stress. The Treg system doesn't work as well. If we then take T cells from normal people and people with cardiovascular disease of various severity and incubate it with increasing levels of oxidized LDL, we're just going to pour oxidized LDL in. You will see as the amount of oxidized LDL exposure increases, you're going to kill off the Treg cells and increase the T17 cells. So oxidative stress knocks off your Treg cells and increases T17 cells, it can actually cause a Treg cell to change into a T17 cell. Now, you would want that if you were exposed to overwhelming sepsis. You don't want any Treg cells quieting down the immune response if you're about to die, so you want a go out and kill them Th1, Th17, take no prisoners immune attack. Then later on, you want Treg. So the immune system can respond to the conditions it finds itself. If it finds itself in an oxidized condition, the artery wall or the heart and heart failure, we lose our Tregs and we go with a Th17 response. Now, let's look at Treg frequency in the various stages of atherosclerosis. We're going to take 69 plaque fragments from 45 patients and classify them into 3 groups. Early lesions, stable fibrosclerotic lesions that you'd see in someone with stable angina, or a high-risk vulnerable plaque. And what you find, this is staining of the artery, normal fatty streak vulnerable plaque, the plaque of somebody that recently had an event. You see more macrophage, you see more lipids, and you see more T cells. You don't see a whole lot of Treg cells. Now, if we look at the percentage of total T cells that are Treg, we actually see more Treg cells in an unstable plaque. Whenever the immune system goes out on attack, it calls in Treg cells because Mother Nature wants you to kill the bugs and then quiet things down. Otherwise, you would have a prolonged maladaptive immune response. You would damage the tissues. So for 1 to 2 days, we want to go out and kill them, and then we want the Tregs to come in. So when we have Th1 and Th17 inflammation in the plaque, the immune system will send in Treg cells, but they don't work very well because of oxidative stress. If you look at the percentage of Tregs in plaque, it's 2%. In normal skin, it's 24%, and in inflamed skin, it's 28%. Elsewhere in the body, the immune system seems to mount a more aggressive Treg response. The arteries appear to be a low Treg environment, presumably from oxidative stress. So our arterial system is more vulnerable to immune dysregulation than is our other organs. Now, the last technical presentation will be soluble CD40 ligand and restenosis, again to illustrate how important maladaptive immune system activation is in perpetuating cardiovascular disease. Then I'm going to summarize and give you some cool case studies. But here we're going to look at soluble CD40 ligand and restenosis. 70 consecutive patients undergoing balloon angioplasty. 26% experienced restenosis, greater than 50% narrowing. We don't want to see that. Now, restenosis was found in a similar percentage of patients with stable angina versus unstable angina, and a similar percentage of these patients received plaque. So the patients were the same. A similar percentage got stents, but 26% experienced restenosis. Why? And then for a control group, we got 10 healthy volunteers. We're going to do baseline lab studies. You're going to carry out the balloon angioplasty. They all got aspirin and Ticlid, which was the precursor for Plavix. It is an antiplatelet agent. Periodically, over the next 6 months, you do lab studies. Then you repeat their angiogram at 6 months, looking for restenosis, and we're going to correlate restenosis risk with the levels of soluble CD40 ligand. Then later on, we're going to do an in vitro study looking at effects of exogenous soluble CD40 ligand on normal human endothelial cells and monocyte activity. Now, when T cells are activated, and they're going to be helper cells, Th1 cells stimulate macrophages to release inflammatory mediators. Th2 cells help B cells release antibodies. They will interact with their target cell with direct contact interaction, membrane-bound tumor necrosis factor alpha, and CD40 ligand binds receptors on their target cell, the macrophage or the B cell, and they will release soluble activators such as interferon gamma, tumor necrosis factor alpha, and soluble CD40 ligand. So the more soluble CD40 ligand floating around, that reflects a greater degree of activation of Th1 or Th17 cells. Now, those who restenosed had much greater concentrations of soluble CD40 ligand than those that did not restenose. In other words, their immune systems were more activated out of control, Th1 or Th17. At baseline, the day of the angioplasty, those who were fated to restenose, their CD40 ligand levels were twice that of those who did not develop restenosis. In response to the trauma of the angioplasty or the stent, there's going to be some immune activation, and soluble CD40 ligand will rise in both groups, but it's brief in those who did not have restenosis. It was greater and more persistent in those that had restenosis. In other words, their immune systems were more activated going into the balloon angioplasty. If you look at the elaboration of endothelial chemotactic factors, ICAM1, VCAM1, E-selectin, that pull in white cells into the plaque, monocytes and T cells, that was greater in those that had restenosis. Their immune system's more activated. Monocyte chemotactic protein encourages the bone marrow to kick out cells to come into the plaque. So the restenosers had more immune activity in their circulation and presumably in their plaque. Now, you're going to take human vascular endothelial cells, you get them from the umbilical cord of a newborn, and you're going to incubate them with serum samples obtained before the angioplasty and from normal healthy controls. So if you incubate these endothelial cells with serum of normal people, you don't see much elaboration of the adhesion molecule ICAM1 or the chemotactic molecule MCP1. But if you incubate it with sera of individuals with coronary disease who did not restenose, and particularly with coronary disease that did restenose, the serum is more toxic. It causes these healthy endothelial cells to activate. So basically, the serum of people with coronary disease have greater degrees of activation of their immune system, and they're releasing the CD40 ligand, which is causing these cells to attract white cells back into the plaque, and this mediates restenosis. The endothelial cells migrate to cover the site of angioplasty or stent. If a stent's put in or there's angioplasty, you're going to destroy the endothelial cells. New endothelial cells need to grow in and cover the plaque to make it stable again. CD40 ligand found in the serum of individuals with coronary disease, particularly those with restenosis, inhibits endothelial cell migration. It increases the amount of free radicals generated from monocytes. So it's another marker of immune activation. So restenosis is in part due to immune system activation. Of course, coronary disease in general was due to immune system activation. The greater the CD40 ligand level, the greater is your risk of restenosis. Now, when a T cell is activated and it starts to proliferate, what makes it proliferate? It releases interleukin-2 and begins to elaborate an interleukin-2 receptor. The interleukin-2 that it releases stimulates its own interleukin-2 receptor, causing it to proliferate and grow more rapidly. And so you have a proliferation, this monoclonal proliferation of T cells. They're all making a lot of interleukin-2. So interleukin-2 is the signal for T cells to proliferate. Now, the drug cyclosporine is used to prevent rejection of transplanted organs. What does cyclosporine do? It blocks interleukin-2. It's blocking proliferation. So if you get a kidney transplant from a non-identical twin, the MHC1 molecules on those cells will be expressing non-self proteins. Your immune system's going to attack the transplanted kidney and try to destroy it. Those T cells have to proliferate into a large enough number of T cells to damage the kidney. Cyclosporine blocks T cell proliferation. That's why it's wonderful in preventing rejection. The drugs, tacrolimus and sirolimus, that are in drug-eluting stents, you know what they are? They also, like cyclosporine, block IL-2. You know, stents were a great advance. With balloon angioplasty, the restenosis rate's 50%. With bare metal stents, that was an advance, but there's still significant restenosis. The drug-eluting stents are highly unlikely to restenose because they're soaked in these drugs that block interleukin-2. So a drug-eluting stent is focal lesion-limited immune modulation. We're going to talk about means of modulating immune system in the entire body, but you can see how important immune modulation is. This is why drug-eluting stents work better than bare metal stents. Now, these drugs will lower restenosis. Other nutritionals that modulate the immune system will also lower restenosis, although it's not talked about anymore because these are not patentable drugs. A study done of fish oil given a month before the angioplasty showed a reduction in restenosis. Now, fish oil works slowly. You have to give it for several months. If you give fish oil on the day of the angioplasty, nothing happens. But if you give it ahead of time, such that the percentage of fatty acids in your cell membrane are rich in EPA and DHA, you see a better looking nuclear stress panel at 3 months. You repeat the angiogram, there's a significant reduction in restenosis with fish oil. Vitamin C, a study done in Japan, they gave 1,000 milligrams a day of vitamin C. They repeated the angiogram at 6 months. Restenosis was blunted. The need for repeat balloon angioplasty fell from 33 to 14%. Vitamin C, by blunting oxidative stress, downregulates the immune system. Fish oil increases T regulatory activity. So these are also helpful in blunting restenosis. We're going to blunt restenosis by blunting the deleterious immune response that caused the arterial disease in the first place and which mediated, in part, it's a major mechanism of restenosis. Again, atherosclerosis begins when lipid particles at high concentration traverse the artery wall at areas of endothelial dysfunction and intimal thickening. Inflammatory enzymes damage the phospholipids, so the LDLs clump together, they can't get out. Free radicals oxidize LDL, initiating an immune response. Macrophages gobble up the oxidized LDL, die, and deposit themselves in the plaque, call in for reinforcements, present snippets of the oxidized L to T cells that mediate the immune response. Over time, the plaque enlarges, more microbes hitchhike in, toll-like receptors are activated, and the plaque ruptures, causing an acute coronary event, and you then have to hightail it into the hospital. How are we going to deal with this? What are our countermeasures? Well, I'm going to outline them here. We'll discuss them in more detail later. Let's get our lipid levels appropriate to the level of immune activation. If you are a young, healthy person, you live in the Garden of Eden, it doesn't really matter what your cholesterol is. It's not going to be oxidized. But if you're 70 years old, you've had 2 open heart surgeries, you have unstable angina, you're in an oxidative storm, I think I want your LDL down to 50 because I know that any LDL in your body is going to get oxidized. So the more advanced your cardiovascular disease, the more inflamed you are, the greater the free radical stress, I want a lower LDL. So it's not that there's a magic LDL number for everybody. There's an LDL appropriate for you. The more advanced your disease, the lower your LDL. Again, it's not LDL, it's oxidized LDL, but if you're going to oxidize all the LDL, I want your LDL quite low. Of more importance, oxidant-antioxidant balance. Get rid of your heavy metals. You want to go through life full of heavy metals, that's fine. We're going to treat you with stents and open heart surgery. A better way is to get these metals out of your body, supplement with antioxidant vitamins and minerals and bioflavonoids, preventing your LDL from getting oxidized. Maintain endothelial tone with exercise, fish oils, arginine. We have a separate presentation on that. So the endothelial cells will resist infiltration with white cells. Upregulate your HDL with essential phospholipid, pomegranate juice, weight control, allergy control. We'll talk about that in the next DVD. Immune modulation. In DVDs 2 and 3, we're going to talk about statins, pentoxifylline, blocking angiotensin II generation and its receptor, famotidine to block the histamine receptor. I'm going to talk about nutritional therapy such as fish oil, testosterone, vitamin D, and one device therapy, ECP. But let me give you a couple case studies to show you how well this works. HR had inoperable coronary disease, 61-year-old man with a really high LDL of 209, high blood pressure, a cardiac arrhythmia, persistent angina. In 1994, he had a heart attack and had multivessel bypass surgery. There was a distal narrowing in the right coronary artery that could not be bypassed. In 2004, he had more chest pain. A stent was placed to the right coronary artery. The vein graft to the circumflex had narrowed. a bare metal stent was placed. He came back a few months later with a heart attack. The stent in the vein graft to the circumflex had re-narrowed, so it was a drug-eluting stent was placed in. A few years later, he comes back with another heart attack. The left internal mammary, left-hand ascending graft looked good, but the vein graft to the marginal had closed again. There's high-grade right coronary narrowing. 2 stents were placed to the right coronary artery. His ejection fraction is down to 25%. It should be 50%. He's sustained a number of heart attacks. He's having persistent angina in November of 2008. And I wanted to do a heart cath. And he goes, no, I don't want you to do a heart cath because you're going to want to put one of those stents, and those stents don't work in me. And I go, well, I really think I should do a heart cath. He goes, nope, I'm not going to let you do it. So we treat him with external counterpulsation, which we'll talk about in the next DVD. And he got better. I felt that I was trying to generate collateral flow to the circumflex distribution, the graft to which had been closed. And he initially got better, and then his pain worsened. Something had changed, so I talked him into a heart cath, and he now had a narrowing in the right coronary artery, and we talked him into a stent, and another narrowing was ballooned because we had to do something. And that didn't work. He comes back with more pain. He had re-stenosed. His ejection fraction is 20%. The best cardiovascular surgeon in Toledo looked at him and said, you know, I'm sorry, I can't do a bypass. There's no vessels I can tie into. So I began him on testosterone, pentoxaline, which we'll talk about later as a pharmacological immune modulator, and he entered our dalcetrapib study. He received either placebo or dalcetrapib to increase HDL. We added that to maximum medical therapy. He's still having pain. We do another heart, he's re-narrowed. So I sent him to the Cleveland Clinic. Can you do a heart transplant on him? He's only 61, and they said, yeah, we can, but right now he's going to be at the end of the list because he's heavy and he's kind of stable, but we'll consider it in the future. Comes into the office in June of 2009 with a rapid arrhythmia, and we had to give him an antiarrhythmic drug called amiodarone. And in April of 2010, the guy's having daily angina, and I got him on everything. Pharmacologic, nutritional, he's inoperable. So I began him on formal immune modulation, the same therapy that our initial patient, the 80-year-old patient who came in with a heart attack, received, and he turned around completely. Just 6 months later, his ejection fractions increased to 35-40%. He's having angina only when chopping wood, and his comment was, how come you didn't do this in the first place? How come you made me go through those stents? Well, the reason was immune modulation is not covered by your insurance. People tend not to want to pay for things out of pocket when there is an insurance-covered alternative. And when I first met him, I had less knowledge of this modality, but I'm sure glad that we treated him because we turned him around by modulating the abnormal Th1 and Th17 immune response that is driving forward his atherosclerosis and his heart failure. Improvement in ischemic cardiomyopathy. DA is an 83-year-old who lives in eastern Ohio. High blood pressure, sleep apnea, hyperlipidemia. Presented, his initial presentation with heart disease was July of 2009. He comes into an outside hospital with heart failure. They did a heart catheterization. His right coronary is closed. The circumflex has only a moderate 50% narrowing. The left end ascending is okay, but his pump function was terrible. He had intermittent atrial fibrillation, a cardiac arrhythmia, and mitral insufficiency. So he was not operable. They put in a defibrillator to protect him against a life-threatening arrhythmia, maximal medical therapy, and a biventricular pacemaker because his heart was activating dysynchronously. By putting in a biventricular pacemaker, we reestablished mechanical synergy. And I saw him in February of this year, and I did an echo, and it looked awful. This is the peristernal long axis view. This is the apical four-chamber view. His heart is enlarged. It is hypokinetic. There's significant mitral regurgitation. Down here is fluid in the chest wall cavity. Ejection fraction is 35%, moderate to severe mitral regurgitation. Heart's dilated. There's evidence of pulmonary hypertension. This is kind of a disaster. So people who have disastrous hearts come to me and I say, welcome, I love taking care of you. So what I did, I added a drug called digoxin to regulate his heart rate. I added spironolactone to block aldosterone, which is a hormone released by the adrenal gland that causes the heart to stiffen. I added a diuretic called zeroxylin to improve the diuretic action of furosemide. And he was already on an ACE inhibitor, lisinopril, a beta blocker, metoprolol, and Lipitor, a lipid-reducing agent. I also added mitochondrial support. When you have heart failure, your heart cells run low in the molecules needed to generate ATP energy, specifically coenzyme Q, carnitine, taurine, and magnesium. Ultimate Cardiofusion is a nutritional supplement that I designed for patients with cardiovascular disease. He began that, idebenone, which is like coenzyme Q, vitamin D, ribose to help make energy, and I put him on famotidine to block the histamine receptor. We'll talk about that later. And I began him on formal immune modulation therapy to really quiet down that T-cell specific immune response in the arteries and in the heart. And I saw him a few months later. He's feeling better, no ankle swelling. He's now mowing the lawn. His BNP, now the upper limit of normal is 100. He was 12,000. It's now down to 7,000, which is really high, but it's a heck of a lot better. I repeat his echo, and it's a heck of a lot better. The heart is smaller, pump function is improved, and the degree of mitral regurgitation had decreased markedly. When the heart is dilated, the leaflets of the mitral valve don't meet together. We call this papillary muscle dysfunction, and you get a lot of mitral insufficiency. By shrinking his heart, the leaflets come together better, and this functional mitral regurgitation resolved or decreased significantly, and that was a really positive finding. And that is the end of the road of DVD 1. We've talked about immune mechanisms of atherosclerosis and how we're going to deal with them. And in the next DVD, I'll introduce immune mechanisms in heart failure and how we're going to deal with them. Thank you very much. Now pop this DVD out and we'll move on to DVD 2. Thank you.